Hi, this is Dr. Nicholas Hatcher, and in this lecture we will review shock and multiple organ dysfunction syndrome. Shock is fundamentally a condition of inadequate tissue perfusion, where there is inadequate blood flow to maintain tissue perfusion. Consequently, there's a state of cellular and tissue hypoxia due to decreased delivery, increased consumption, or inadequate utilization of oxygen. There is also a consequent state of impaired glucose delivery and utilization. Shock progresses through some predictable stages. We will go through each of these in more detail. The first of these stages is the Systemic Inflammatory Response Syndrome, or SIRS. In Systemic Inflammatory Response Syndrome, there is an initial insult that results in cellular activation. The insult can be from a variety of conditions, including infection, allergic reaction, and trauma, among others. This cellular activation results in the release of a variety of chemokines, including histamine, kinins, prostaglandins, leukotrienes, and complement. The specific consequence of each of these is listed here, but the overall result is SIRS. The goal of SIRS is to return the body to a state of homeostasis by essentially mobilizing the system. There are four major events of SIRS. The first is peripheral vasodilation. The second is increased capillary permeability. The third is cellular activation. And the fourth is microvascular coagulation. These are the ultimate results of SIRS. When the patient is immunocompetent and in check, the patient returns to homeostasis. We can identify SIRS clinically by the presence of two or more of the following symptoms: altered mental status, tachypnea, a fever greater than 100.4 degrees Fahrenheit, hypothermia with a temperature less than 96.8 degrees Fahrenheit, decreased capillary refill, hyperglycemia with a blood glucose greater than 140 in the absence of diabetes mellitus, leukocytosis, leukopenia, bandemia, an elevated C-reactive protein, and an elevated procalcitonin. The next stage we will discuss is compensated shock. In compensated shock, we may see early signs and symptoms of shock. The clinical presentation is relatively stable, and at this point there are moderately effective compensatory mechanisms in place. The outcomes are as follows. If the cause is rapidly corrected, there are minimal residual effects. If it is not corrected, the body enters the uncompensated stage. At this point, because of the changes in vascular permeability, vasodilation, cellular activation, and microvascular coagulation, there is resulting hypotension. This activates two pathways. The first is baroreceptor activation and resulting nervous system activation with consequent release of epinephrine and norepinephrine. These two chemicals act to increase heart rate and contractility, as well as improve vascular tone, respectively. The second pathway is activation of the renin-angiotensin-aldosterone system, or RAAS, which results in fluid retention that ultimately improves cardiac output. The overall goal of these pathways is to improve tissue perfusion and oxygen delivery. Here I've listed findings consistent with compensated shock. The patient is alert and oriented. There is tachycardia as well as borderline hypotension, tachypnea, nausea and anorexia, a decreased urinary output, hyperglycemia, and the extremities are cool to touch. The overall picture here is that blood is being shunted to the brain, heart, and lungs. Now let's discuss uncompensated shock. In uncompensated shock, there is development of rapid patient deterioration. compensatory mechanisms begin to fail. Aggressive interventions are needed to prevent the development of multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome, or MODS, is defined as the failure of two organ systems. This is the presence of altered organ function in acutely ill patients. When MODS sets in, organ system homeostasis cannot be achieved without intervention. The compensatory mechanisms we discussed previously are no longer adequate to maintain tissue perfusion and oxygen delivery. In this case, we begin to see widespread damage as a result of impaired tissue perfusion. In the upcoming slides, we will look at the core issue of impaired tissue perfusion, which is reduced oxygen delivery, on a cellular level, so that we can appreciate the larger picture of what uncompensated shock does to the system. The best place to start is with the question, why do we need oxygen? We need oxygen as the final electron acceptor in the electron transport chain, as part of oxidative phosphorylation in the process of ATP production. The presence of oxygen allows for the highest yield of ATP through the process of aerobic cellular respiration. In the presence of impaired tissue perfusion, the lack of oxygen shifts us over into anaerobic metabolism. As a result, instead of breaking pyruvic acid down into acetyl coenzyme A, that will then enter the Krebs cycle and ultimately the electron transport chain, pyruvic acid is instead converted into lactic acid under the influence of lactate dehydrogenase, or LDH, primarily in the liver. As the name illuminates, lactic acid is an acid and contributes to acidosis of the system. About 70% of the ATP produced by cells is used to maintain sodium-potassium pumps. Therefore, in the setting of hypoxemia, there is decreased ATP production that causes failure of sodium-potassium pumps and metabolic acidosis from lactic acid buildup. This results in a shift of potassium and sodium movement. Sodium moves into the cell, and potassium moves out. Because of this, there is a shift in osmotic pressure. Water moves into the cell. Mitochondria and lysosomes swell and rupture, and there is resultant cellular edema and cell death. On a larger scale, this is the underlying issue of all shock states. There are additionally some vascular changes that occur at this point. Cellular hypoxia activates monocytes, which results in cytokine release, which triggers a cascade ultimately leading to vasodilation and further increased vascular permeability. This contributes to a worsening of impaired tissue perfusion and hypotension. Here I've listed several findings that you can see in uncompensated shock. The overall theme is a lack of reserve and systematic failure of organs. Finally, let's look at irreversible or refractory shock. This final stage of shock carries a 96 to 99% mortality rate. There is loss of almost all compensatory mechanisms. Decreased perfusion exacerbates anaerobic metabolism processes. Vasodilation and increased vascular permeability results in plasma leaving the vascular space, contributing to profound interstitial edema and loss of intravascular volume. This results in refractory hypotension, end organ ischemia, multiple organ dysfunction syndrome, and ultimately death. Here I've listed findings consistent with irreversible shock. Now let's discuss the general management of shock. In managing shock, always consider airway breathing and circulation as a priority. In this case, you may need to assist with intubation, provide oxygen to maintain a saturation greater than 90%, and administer IV fluids blood, or albumin. These patients will require at least 2 large bore IVs, but you may be assisting with central line placement. It's important to maintain these patients on a cardiac monitor and check vital signs frequently. Monitor I&O and potentially consider a Foley catheter. For positioning, it's generally recommended to maintain the patient supine with legs raised. The Trendelenburg position is no longer recommended. Maintain normothermia. Too much heat contributes to further vasodilation, which counteracts any compensatory vasoconstriction and increases fluid loss through perspiration. Early enteral feeding is best in terms of nutritional support. Pharmacologically, vasopressors should be considered after volume replacement. Let's go into a little bit more detail on vasopressors. An important principle to keep in mind is that you need to prime the pump before squeezing the pump. Squeezing the pump will get you nowhere without something to pump. This refers to ventilation, oxygenation, packed red blood cells, IV fluids, and even platelets. Having something to pump will get you nowhere without an adequate squeeze. Therefore, vasopressors are implemented in order to assist with this squeeze. The basic idea is to ensure that the patient has adequate volume to move about their system. You can think about this like an IV pump, in that it will not function if tubing is not primed. Here I've shown some key receptors and where their function lies. Beta-1 receptors are primarily in the heart. Beta-2 receptors are primarily in the lungs and periphery. Alpha-1 receptors and V1 receptors are likewise at the periphery. Finally, there are dopamine receptors in the vasculature of the kidneys that are thought to be associated with vascular permeability there. In this image, I placed the vasopressors on a spectrum based on their relative affinity for alpha and beta receptors. I've listed dopamine as a separate medication on the bottom because it's different in that low doses purely targets beta receptors, but at higher doses it has a tendency to target more alpha receptors. In this chart, I provided the relative strength or affinity of vasopressors for various receptors. You'll notice that vasopressin is unique in that it only targets V1 receptors. Dopamine is unique in that it targets dopamine in addition to alpha and beta receptors. Across the board, the following are considerations regardless of the type of vasopressor. Number 1, you could potentially see tachyarrhythmias with any vasopressor. Because of this, you want to titrate it carefully and maintain the patient on a cardiac monitor. Blood pressure will likely fluctuate. Therefore, it's important to do blood pressure checks every 30 minutes to an hour. Extravasation of a vasopressor can result in tissue necrosis. This is why sometimes it's important to use a central line instead of a peripheral line for vasopressor use. If this occurs, the treatment is subcutaneous phentolamine or Regitine, and 5 to 10 milligrams is injected to the affected areas. Alternatively, nitroglycerin paste can be used. It's also important to note that acidemia blunts the catecholamine response, and that refers to epinephrine and norepinephrine. Therefore, higher doses may be required. It's also important to consider the treatment of the underlying acid-base imbalance. This is also important to consider because as the underlying acid-base imbalance is corrected, you may not need the higher dose that you required before. A final consideration is central shunting. Patients on vasopressors will typically have cool extremities and potentially digital ischemia. This is expected to some degree, but can be problematic if persistent. Now we will discuss specific types of shock. The first type of shock we will discuss is hypovolemic shock. Here there is a loss or redistribution of volume in the form of blood, plasma, or other body fluids, which results in decreased intravascular volume. Manifestations are noticeable when the intravascular volume is reduced by greater than 15%. The result is inadequate preload that contributes to decreased diastolic filling and decreased cardiac output. Some common examples of blood loss that results in hypovolemic shock include hemorrhage, penetrating trauma, gastrointestinal bleed, aneurysmal rupture, ectopic pregnancy, and postpartum hemorrhage. Examples of plasma or interstitial fluid loss contributing to hypovolemic shock include severe diabetes mellitus, usually in the form of diabetic ketoacidosis or hyperglycemic hyperosmolar non-ketotic syndrome, diabetes insipidus, hyperemesis, diarrhea, particularly like in the form of C. diff, overdiuresis, and pancreatitis. The diagnosis of hypovolemic shock is clinical with the support of adjunctive findings. It's important in these patients to check an ABG, CBC, BMP, coags, urinalysis, a pregnancy test, and type and cross. As far as imaging is concerned, it's debatable whether or not to use targeted versus whole body imaging. A fast exam can be performed via ultrasound to look at key areas to identify hemorrhage. The purpose of the diagnostic workup is to find and treat the underlying cause. It's important to note that patients on beta blockers, calcium channel blockers, or with pacemakers may not have tachycardia in response to hypovolemia. Treatment includes packed red blood cells for hypovolemic shock due to blood loss. Platelets and coagulation factors should be used when large amounts of blood are needed. It's important with massive transfusion to monitor calcium for hypocalcemia. If available, warm the blood because blood can produce a cooling effect, contributing to dysrhythmias, paradoxical hypotension, decreased oxyhemoglobin saturation, or basically the mobility of oxygen through the system, and cardiac arrest. Obstructive shock is the result of mechanical obstruction impacting the cardiovascular system that causes decreased ventricular emptying and/or decreased ventricular filling. In this image, I provided several examples of things that may cause obstructive shock. These include tension pneumothorax, vena cava compression or thrombus, cardiac tamponade, pulmonary embolism, and aortic dissection. Treatment emphasizes rapid identification and treatment of the cause. There should be gentle volume and pressor use because this is a temporizing measure only. I provided some examples here. For instance, if the patient has a pulmonary embolism, some of the key findings that may point to a PE include isolated hypoxemia, DVT, or coagulopathy risk factors. The treatment would include thrombectomy or tissue plasminogen activase, or TPA. Cardiac tamponade presents with a classic triad of hypotension, jugular venous distension, and muffled heart sounds. The treatment for this is pericardiocentesis or pericardial window. In the event of a pneumothorax, the key finding would be unilateral absence of breath sounds, and the treatment for this is needle decompression and chest tube placement. Cardiogenic shock can be described as a situation where there's cardiac dysfunction, persistent hypotension, tissue hypoperfusion in the setting of adequate intravascular volume and left ventricular filling pressure. This is different in comparison to hypovolemic shock, where there is inadequate intravascular volume and left ventricular filling pressure. In cardiogenic shock, the cause is usually in the form of valvulopathy or ventriculopathy. Essentially, the heart fails as a pump, and there is decreased contractility that leads to decreased stroke volume, decreased cardiac output and blood pressure, and decreased tissue perfusion. Here I've listed some common causes of cardiogenic shock, with myocardial infarction being the number one cause. Additional causes include heart failure with reduced ejection fraction, or HFrEF, or acute decompensated heart failure, ADHF, and this can be ischemic or non-ischemic, hypertrophic or obstructive cardiomyopathy, myocarditis, cardiac contusion, papillary muscle rupture, intraventricular septal rupture, and dysrhythmias. For the presentation of cardiogenic shock, think cold and wet. The patient is ashen or cyanotic, with mottled extremities, altered mental status, rapid diminished pulses that may be irregular, cool skin, jugular venous distension, pulmonary rales or crackles, precordial heave, distant heart sounds with an S3 or S4, and a systolic murmur. In terms of diagnosis, the key differentiation is that there is no obstructive cause, so there's no obstructive shock, and there is adequate volume, so it's not hypovolemic shock. By definition, the cardiac index is less than 2.2 liters per minute per meter square, with a pulmonary capillary wedge pressure greater than or equal to 15 millimeters mercury. Other things that are suggestive of cardiogenic shock include an elevated brain natriuretic peptide, or BNP, greater than 100, pulmonary edema on chest X-ray, and an abnormal echocardiogram. In terms of management, if there is a myocardial infarction, the goal is to restore coronary artery perfusion. This is done via anticoagulation, angioplasty, stent, and/or CABG. No nitrates are used because this worsens hypotension. If the problem is heart failure, then inotropic support and afterload reduction, for instance with the vasopressor dobutamine, is the goal, in addition to diuresis. If the issue is dysrhythmia, then an appropriate antidysrhythmic drug, cardioversion, and/or defibrillation may be used. Now let's discuss distributive shocks. With these forms of shock, there's a problem in distribution, and they include neurogenic, anaphylactic, and septic shock. With neurogenic shock, there's basically an imbalance between the parasympathetic and sympathetic branches of the autonomic nervous system. The sympathetic nervous system maintains vessel patency and resistance. Spinal cord injuries are by far the most common cause of neurogenic shock. In this example, a T6 or above spinal cord injury results in disruption of sympathetic pathways, causing a decrease in sympathetic tone distal to the level of injury, contributing to unopposed parasympathetic tone. This results in bradycardia, massive vasodilation that contributes to hypotension, and an inability to regulate body temperature. The key difference in this form of shock as opposed to all others is that it's the only form of shock that presents with bradycardia. I've listed some additional examples of things that can cause neurogenic shock below. In terms of treatment, immediate neurosurgery consultation is needed for spinal stabilization and surgical decompression. It's important to avoid activities that trigger the vagal response, such as suctioning, vomiting, and the Valsalva maneuver. Volume is given as needed in addition to vasopressors to maintain a mean arterial pressure between 85 and 90 for spinal cord perfusion. It's important to avoid phenylephrine because of unopposed alpha activity. Chronotropic support is provided by atropine or epinephrine infusion and potentially a pacing device. Methylprednisolone is helpful if given within 7 hours of injury. Finally, warming blankets and environmental regulation is helpful for hypothermia. In anaphylactic shock, re-exposure to a specific antigen results in an IgE-mediated response or mast cell degranulation, which is non-IgE related, resulting in the release of histamine, prostaglandins, and other vasoactive mediators. These result in massive vasodilation, capillary permeability, and constriction of non-vascular smooth muscle. Here I've listed some very common causes of anaphylactic shock. Note that this is not a full list, as any form of re-exposure can potentially lead to anaphylactic shock. It's interesting to note that 30 to 80% of patients with a latex allergy are also allergic to fruits such as bananas, avocado, and kiwi. Anaphylactic shock is characterized by urticaria and angioedema, but you can also see symptoms of anxiety, GI cramps, hemolysis, and fever. In terms of management, it's important to consider early intubation to maximize oxygen delivery. You want to consider early intubation because as anaphylactic shock progresses, the angioedema can potentially become worsening, making it difficult to intubate down the road. Adrenergic agonists such as epinephrine are a frontline treatment. In this case, you would use IM epinephrine as opposed to IV epinephrine. IV epinephrine is reserved for treatment of cardiac arrest. Additional treatments that may be used include H1 receptor antagonists such as diphenhydramine, an H2 receptor antagonist such as famotidine, a bronchodilator such as albuterol, corticosteroids such as methylprednisolone, and vasopressors such as an epinephrine drip. Patients with anaphylactic shock should be monitored closely because there's a risk of sudden reoccurrence of anaphylactic shock within 6 to 12 hours after the initial reaction. This is driven by basophils and macrophages. It typically follows a favorable response to treatment during the initial phase and is treated the same way. It has implications for airway management, line maintenance, and ICU care. Sepsis is defined as a malignant intravascular inflammation. It's malignant in that it's uncontrolled and self-sustaining. It's intravascular in that blood spreads cytokines confined within the interstitial space. It's inflammatory in that sepsis is essentially an exaggerated inflammatory response. Basically, in response to a pathogen, the body over-responds with release of various cytokines. This storm of cytokines is recognized by endothelial receptors. Once recognized, there is a breakdown of vascular endothelial cadherins, or the bridge network that is maintained between the endothelial cells. Impairment of this bridge results in leakage of fluid into the interstitial space, increasing the distance that oxygen must travel, therefore contributing to impaired tissue perfusion. Sepsis occurs on a continuum. This continuum starts with sears, as discussed earlier. The next step is sepsis, defined as sears plus a known or suspected infection. The next step is severe sepsis, defined as sepsis with hypotension responsive to fluids. The final step is septic shock, which is defined as sepsis with hypotension that's refractory to fluid replacement. Sepsis treatment is typically broken into 3 and 6 hour bundles. In the 3-hour bundle, it's important to administer a 30 milliliter per kilogram crystalloid bolus, check the lactic acid level, draw blood cultures, and initiate antibiotics. Treatment is most successful if antibiotics are started within the first hour of presentation. In the 6-hour bundle, treatment moves into a focus on hemodynamic monitoring, giving more fluids, and maintaining the patient on vasopressors. The vasopressor of choice in septic shock is norepinephrine, with augmentation through the use of vasopressin. In this final section, I'll go into a little bit more detail on multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome is defined as progressive dysfunction of two or more organ systems resulting from an uncontrolled inflammatory response to a severe illness or injury. It's important to note that the pulmonary system is often the first to be altered. Dysfunction and failure of two organ systems has a mortality rate of 40 to 67%. Dysfunction and failure of three or more systems has a mortality rate of 60 to 100%. The greatest risk for multiple organ dysfunction syndrome is in the elderly, in those with significant tissue injury or pre-existing disease, and in those whom there was delayed or inadequate resuscitation. In multiple organ dysfunction syndrome, there are three key factors contributing to the development of the syndrome: imbalance of oxygen supply and oxygen demand, maldistribution of volume through vasodilation and third spacing, and alterations in metabolism, where the patient is hypermetabolic. If maldistribution of volume, oxygen supply and demand imbalances, and metabolic alterations cannot be slowed or reversed, then MODS occurs. Once the inflammatory or immune response is overactivated, the body can't clear the mediators and toxic metabolites fast enough, and a self-perpetuating cycle develops. In looking at the trajectory, at approximately 24 hours, there will be low-grade fever, tachycardia, tachypnea, dyspnea, altered mental status, general hyperdynamic and hypermetabolic state. At 24 to 72 hours, there is the beginning of lung failure and possibly the appearance of ARDS. Between 7 and 10 days, there is development of hepatic, intestinal, and renal failure. Between 14 and 21 days, there is increased severity of renal and liver failure, and also possibly death. Later issues include hematologic and myocardial failure. In terms of management, there is no specific therapy. Prevention of the syndrome is essential. It's important to localize the initial source of inflammation and avoid a second insult. Goals include, but are not limited to, infection control, tissue oxygenation, and support of the function of individual organs. Here are my references. Thank you for watching.